Hello and welcome to North Country Matters. My name is Donna Seymour. I'm a member of the St. Lawrence County League of Women Voters, one of the civic partners for our show. My guest today is Stephanie Rogers. Stephanie is a nurse practitioner with Hospice of St. Lawrence Valley. She's here to talk to us about palliative care through the AIM program. Stephanie, welcome to North Country Matters. This is the second in our series of shows about the services that Hospice of the St. Lawrence Valley can offer to folks in our area. We're happy to have you to talk to us about the AIM program. We always ask our guests to tell us something about themselves and how they came to be doing the work they do. So, what is your story, Steph?
Well, thanks for having me, Donna. My story, I've been in medicine for about 18 years. I was a ER nurse for 10 years. You see a lot of, chronic disease, a lot of death, end of life processes, that kind of thing. And then I decided to go back to school and become a nurse practitioner. And after that, I worked about 4 or 5 years as a hospitalist, taking care of patients in the hospital. And that included taking care of an ICU at night, where you have a lot of hard conversations. While I was doing my nurse practitioner degree, I was fortunate enough to take an intro to palliative care course. And that got me connected, because we had to do a project, got me connected with Hospice of St. Lawrence Valley. I got to learn more about their program, and that put them on my radar. And like you, my father at the last stages of his life had AIM, and it was very impactful. It was very a bird's eye view into how profound the program can affect families. And when I decided I needed a change of pace and AIM needed nurse practitioners, that's how I got here.
So your story is really one of professional development and an every taking advantage of opportunities that came up. I had mentioned before we went on the air about my dad. My dad was in the last few months of his life had a lot of recurring trips to the emergency room, and my sister and I were helping to take care of both of my parents at the ends of their lives. And as my sister said, we learned a lot through desperate circumstances and desperate need in our personal experiences, and what a relief it was to have the support and access to assessments and caregiving and compassion with understanding that hospice and AIM gave us. So that's really why I think can have a great conversation today, because we're not the only people who've been through this experience by any
No,
means.
no.
So AIM stands for Advanced Illness Management or Palliative Care. Explain for us what that entails and how it differs from hospice care, please.
Okay. And that's a common misconception. The name sort of gives a little bit of it away. We take care of patients who have advanced illness. The difference between that and hospice is hospice patients are usually no longer seeking curative care. They're focusing on comfort, and they've been deemed to have 6 months or fewer left in their life. For my patients, I often say, and don't get me wrong, we all have an expiration date. My patients don't have a definite, predictable expiration date. It can be for many different things that you would qualify. It could be congestive heart failure. It could be COPD. It could be some sort of cancer where you're seeking curative care. Any, dementia, end stage renal disease, end stage liver disease, any sort of, or any combination of those, where patients are seeking disease specific care, but still they're finding that they're calling the doctor's office a lot more often, or they're having more ER visits, or they can't get in to see their primary care provider, or they just can't get out of the house anymore because they're just not mobile. And clues when people are ready for care might be the family needs to get more involved. And a lot of people benefit from having somebody come into the home every 4 to 6 weeks, which is what we aim at. Patients don't have to abandon their current primary care providers or any of their healthcare providers. We work in conjunction with their healthcare providers, And working in this area in medicine for as many years as I did, I know many of the healthcare providers, and we work cooperatively. And that's a difference in hospice, where patients are no longer going to the ER, they're no longer going to their care providers. We can talk about the goals of care, and get a good sense of what the patients want. Being able to go into the patient's home gives a really important angle on what, you see a totally different side of a patient when you're in their environment. You see problems that could come up. You see, things that they could use in the home that they might need, like durable medical equipment. And we can order that. I can prescribe medications. If a patient thinks they have a UTI, I can, order a urinalysis and have them take a urine sample in, prescribe antibiotics, and advise on whether what they're experiencing may warrant an ER visit, or if it's something we can take care of at home. So it also provides comfort to the families, because obviously the patient isn't the only one who suffers from chronic disease.
Yeah,
So
you make a
that,
really good point about that, because so much of what the AIM program really does is about educating patients and family members about the disease really is. And I think we've all had the experience of going to a doctor's office, and there just isn't time to get into all of the details and really understand what the prognosis is for that course of disease. And as you mentioned earlier, so many people suffer from more than one chronic disease. So how do those interact? How do the medications interact? There's a lot of education that goes into this, which you and your program can help provide.
yes, yeah, absolutely. And our goal is to, improve quality of care, in that we're that's similar to hospice, in we deal with troubling symptoms that interfere with quality of life. And a lot of times, there's either a medication for that, or there's something they're taking that's causing it, or we need to rearrange their medicine so they're taking something at night instead of during the day. There's just there's a lot of education, and a lot we can do, just being there and seeing the patient. We see, how the patient's progressing through the disease, because we see them every month. So that's very helpful in being able to treat them.
Yes, it is. And as you mentioned, being able to see them in their own home and their own environment, because a doctor's office doesn't give you any clues about how people are living and getting along. So that is, it's very important that you have those eyes on not only the patient, but on their surroundings. So, Stephanie, let's talk about who benefits from the AIM program. Can you give us a scenario where AIM would be a great choice for a family?
Yeah, absolutely. I can think of a few right off the top of my head. Especially, I have several patients whose family members are older, they're having memory problems, and they live alone. And the family members are trying as hard as they can to keep the patient in the home. And they do things like they'll put up cameras, and they come in frequently throughout the day, or they'll have some caregivers come in and help them out. So I can go in every month, and I do a mini exam, and we go over medications, do some vital signs, listen to their heart and lungs. I can see if their ankles are swelling up, or if they look like they're fluid overloaded, or if there's a lot of wheezing going on today. And it helps to keep patients out of the ER, or I can alert the family, I don't think this is a safe arrangement anymore, or I don't think she should be managing her own medications, or, those kinds of things. And that can be true of many different illnesses. So, it's just good to have eyes on the patient more frequently than every 3 months or 6 months, or however often they're seeing their PCP.
It also takes some of the burden off the family in terms of sometimes making those hard calls about, you really
Yeah.
can't manage your medication anymore, because the patient's going to be much more resistant to a family member saying that than they are an outside professional who really
That's
has a
true.
lot of experience. So I think that's another important aspect to this is that sometimes they'll listen to you where they won't listen to their wife or their husband. So
That is true. And a lot sometimes they don't want to have to be the ones to say it.
that's
You
right.
know, if I say you shouldn't be driving, you can't see this form I just had you sign, and the family member can say, see, mom, that's what I said, remember? And sometimes they will listen to me, sometimes they won't.
Yeah, exactly. And so those are, and when you're the person going through it, the assumption always is, well, I'm going to get better and I'm going to be able to go back to what I was doing. But the truth is that when you have that many chronic conditions, getting better is always going to be incremental at best because something else is fighting your getting better, isn't it?
And it doesn't take much to throw people off. One cold, one hospitalization, one fall, that can make the difference to interrupting their progress. And when you see mom or dad or husband, or you see them sort of declining and you're not sure, should I be doing something? We can discuss disease progression. There are plenty of diseases that have sort of a stepwise progression. We can see what's happening, and I can give them sort of a clue what to expect. There are plenty of diseases that don't have a definite progression, and we just have to say, let's just see how it goes next month. He does seem weaker. Let's try this.
Yeah, and of course, the older you are, the slower you are to recover. So it's
Yeah.
always frustrating for the patient for sure. Well, I should be better by now. And and I think we all have a tendency to think, well, somebody prescribed a pill, but that didn't make me better overnight. And we've all been kind of socialized to think that medication is always the answer, and sometimes it's not, is it?
No, no. And it can be very frustrating for the family when dealing with patients who either just don't feel good and they're grumpy, or mom who asks the same question over and over, or she's talking to you about her daughter and you're her daughter, or those questions that they ask over and over, or if they start to perseverate on something that makes them very upset, you can sort of teach them how to redirect, how to talk to them and not be condescending. When they ask the question the 15th time, how you just kind of answer it just like you did the first time, that kind of thing. And it's reassuring that it happens to other people. And sometimes just giving them that information helps a lot.
Yeah, I think you're right about that. So, Stephanie, describe for us who makes up the AIM team. Obviously, you're the nurse practitioner, but you don't operate in a vacuum, do you?
Absolutely not, nor could I. And there are three nurse practitioners, myself, Donna Goki, and Sonia Koken, who we sort of are fortunate enough that we live in different parts of St. Lawrence County, that we kind of divided up so that we're traveling in a smallish area. And then we have our program director, Michelle Harriman, who I'll have to get my spreadsheet out to tell you all the things she does. She handles all the scheduling, all the referrals, all that's so reductive to, she does pretty much everything else. And then we have our AIM support specialist, Ashley Matthew, who keeps everything running from behind the scenes, answers the phones, deals with all of our paperwork, deals with patients, that kind of thing. And if 5 people doing that job sounds like not a lot, you get a sort of a sense of how much everybody is doing. But it's a really good team. And because we work closely with the hospice team, they're essentially all part of that too, even though we're
Well,
separate.
this is a very big county, as you mentioned, with just trying to divide up going to do the visits, the home visits that you have to do. So it takes a big team in order to manage all that and to take care of people. So when your colleague Kate Favreau was here last month, she walked us through the kinds of end of life care that hospice offers. Explain to us how AIM can help families cope with a loved one's advanced illness. I know you've talked about some things, but that really is a big part of your job, is supporting the families, isn't it?
Yes, yeah. And discussing disease progression, and reiterating end of life wishes, because some people, they know that hospice maybe is going to be the eventuality for them, but they're not ready, and they're not sure when they should. And that in that way, I can help have that conversation. One of the things, we learned about in Intro to Palliative Care is that, and this is probably an old stat because it's from, before 2019, but at that time, the average hospice patient who qualifies for 6 months worth of hospice was using 88 days worth of the hospice benefit. And it really is a huge benefit, as you heard from Kate. So if we see that the families could definitely benefit from it, we can sort of coach them and, guide decision making. And yeah, as I said before, the progression of disease and just sort of guiding that in that way.
With your experience and your colleagues' experience, I'm sure guiding people to say this is the time to start thinking about that is much easier for you than the people who are involved in the patient's care, family members, because they, I'm sure, still keep hoping things are going to get better. And,
Yeah.
they, unfortunately, they don't always get better. So that's for sure. So how do you determine when palliative care should be the choice, Steph? Are there things that families can use as markers to help them make that decision that they should be calling in your side of the program?
Yeah. And I'm glad you asked that because hospiceslv.org, the website under services, has a lovely tool that will help you to determine do you need AIM or do you need hospice? And it walks you through, how much can the patient do for themselves? Have they had a recent decline in either health or function, or, are they relying more on others? Are they having more symptoms, shortness of breath, chest pain, that kind of thing? Are they having more ER visits? Are they, that kind of thing? Are they requiring more? But I would strongly encourage somebody who thinks they might, that might be a good thing for them to use that tool, because it's I went through it a couple of times and thought, I wish I'd known that that existed.
Yeah, and I know in my dad's case, he was a frequent flyer at the
Yeah.
ER, and it
Yeah.
seemed like about once every 3 or 4 weeks we had him in there, and obviously that wasn't taking care of the issue. And both my sister and I said if we had we but known, we could have
Right.
brought in the AIM team sooner, because at that point he wasn't ready for hospice, but he certainly would have benefited more from that. And we just didn't do it soon enough, which is, I'm sure,
Yeah.
something you hear from people all the time.
Yeah. And if you ask yourself, would I love to be able to call somebody and say, what should I do? What should I do with my loved one? This is happening and this is happening. And should we go to the ER? Should we do this? Should we do that? We're unfortunately a lot more accessible than a lot of the primary care providers.
Well,
But
that's
it's helpful to the primary care providers too. And I've heard that a lot.
sure. I'm sure it is, because that clogging up their phone lines in their offices with
Yeah.
people who don't really need to be there but aren't sure. So,
Mhm.
that giving people assurance is a huge part of what you do. So let's talk, Stephanie, about how people can connect with the AIM program and what they should do when they're ready to call.
Okay, so I mean, if you're ready to call, should I just shout out the phone
Go
number?
right ahead. I'll put it in the show
Okay,
notes, but feel
all
free.
right. Just go ahead and call Ashley. Our main number is 315-262-0861. You can refer yourself, your family member can refer you, your doctor can refer you. And that's just give them a call, talk to Michelle, and they'll walk you through it.
Okay, so that sounds and you don't have the same restrictions that hospice has when they like a 6 month time frame.
Right,
You can do
right.
this for much longer period of time if it's needed, correct?
I've seen patients for over a year. So
Okay. And so if you are somebody who needs that extra relief, you need those questions answers, don't hesitate to call, because they're more than happy to help you out. And even
right.
if it turns out that AIM isn't the right choice, at least they've had somebody explain to them why it isn't or what to look for, so when it is, that they'll feel free to call again, right?
Right, right. And that usually, Michelle walks people through and
Mhm.
explains it. And, if they don't necessarily qualify, then, she would explain that to them. The other thing that happens to me, has happened multiple times, is I see a patient for the first time on AIM and it's clear that they qualify for hospice,
Okay.
and we move them right over to hospice. When they go to hospice, I continue to follow them, so we have continuity of care. So we
So
can we
that's,
can
and
help you
again,
through it.
that's that outside experienced eye looking at the situation that a patient is in, and it can help make those determinations because family members usually don't go through this enough to be very experienced, do they?
Right. You were talking before about on the job training, learning things by trial and error.
Yeah, exactly. So the next question I want to ask is probably what's the most important in a lot of people's minds is tell us about what the program costs. Is there a cost for the AIM services? How is it paid for?
So it is covered under Medicare Part B. It's covered by Medicaid and covered by private insurance. Some patients will have a copay. If you have a copay, say when you go to a specialist, that might also apply here. But financial constraints should never be a reason not to call. We don't turn anybody away, and we can definitely work with you if you've got a financial situation. So I
Okay,
strongly encourage to not to worry about the money portion.
that's a really important part because I think so often people are afraid that they're going to get into a financial bind, even though they need help. They just don't feel comfortable picking up that phone and making the call for fear that they're going to be get behind that financial eight ball. So
Right.
that's very encouraging. So as we wrap up, Stephanie, what are your final thoughts on this? Do tell people what they need to be thinking about and not to hesitate to call because that's certainly the message that you've given us.
I call AIM the best kept secret in St. Lawrence County. And I most people that we sign on are grateful just to have, eyes on the patient, and I'll often say, why didn't I do this sooner? You know, we're here, we're here to help. We're here to keep your family members home as long as possible and healthy as long as possible, and get them feeling more like, their quality of life is worth it. And just to get you connected with, we have the ability to connect with services like Office of the Aging, and having the guidance, and if nothing else is often helpful.
One of the services that we took advantage of for my parents in their last few months was Meals on Wheels. Uh,
Oh yeah.
yeah,
Yep.
so that, and again, that was a suggestion when we brought Hospice and AIM in to talk to us. That was a suggestion because by that point, my mother didn't feel like cooking and my dad couldn't cook for
Yep.
himself. And so if she didn't feel like cooking, he didn't get very much to eat. So he used to rave about how the meals were so good and how the portions were just perfect. So,
Yeah.
all these services that people don't really know about and then they have to struggle to find. So I think that what you offer is such a great service because it isn't just hospice, it isn't just AIM, it's connecting to these other agencies as you talk about that people may not have a connection to.
Right, right. And I've got a pretty well-rounded area of expertise. So I'm comfortable talking to the cardiologist. I'm comfortable talking to the nephrologist. I'm comfortable talking to your primary care provider. And pain management certainly is a specialty. So and we do a lot of it. So I wouldn't hesitate to call. You don't have anything to lose, really. I
No,
mean, if you decide it's not for you, then just say thanks.
or
Thanks,
if
thanks,
it's
I'm good.
or if it's not for you right now, but it might be a few months down the road. And
Yep.
starting that conversation early is important because it opens up those avenues later on when things are a little bit more desperate. So, thank you. One last question, Stephanie. So we talk about trying to keep people in their homes because that's where they're the most comfortable, and that's where it's really the most cost effective because there aren't very many There aren't many
Yeah.
skilled nursing home beds in this county for sure.
No.
And we don't have any assisted living anymore. So really keeping people at home makes a lot of sense. But there are times when it just isn't feasible anymore. And that's one of the services that you can help offer, is to make that determination and help people get into a safer situation, correct?
Yeah, yeah, that's we try to encourage people to stay home as long as possible, but at a certain point, it's not if it's not safe and they need more help, then we can help figure out when that is, what time, when it's time.
Well, Stephanie, thank you so much for coming in today. You've really given us a lot of really good information about the AIM program and how it can really take some of the burden off the families who are dealing with sometimes multiple health issues with a family member. And it can feel very overwhelming. There's hardest job in the world is being a caregiver without support. So you are really a huge support network for caregivers in this county, aren't you?
Yeah, and I enjoy it. I really get a lot of value from it.
Well, thank you very much. And we're this is a continuing series that we're doing with hospice and the various programs that they offer. So stay tuned for more information about the great work that hospice does. Stephanie, thanks again so much for coming in.
Thanks. It was wonderful talking to you, Donna.
Well, I enjoyed it myself. So these conversations are a production of North Country Matters. This show is a civic collaboration between the League of Women Voters of St. Lawrence County and the Potsdam Public Library. Until next time, remember, our North Country matters.